go ahead and do some of our introductions. Let me just share my screen. We're very grateful to have a lot of people joining us tonight and some really good work to cover. So thank you everybody for joining us for the November episode of the JVS Journal Club. We're going to be covering 2 articles from the November JVS, which is preoperative risk score accuracy confirmed in a modern ruptured abdominal aortic aneurysm experience from the University of Washington, as well as some of their co-authors from Hawaii who are joining us in Thailand. And then the second article is the effects of supervised exercise therapy on blood pressure and heart rate during exercise and associations with improved walking performance in peripheral artery disease, results of a randomized clinical trial. Tonight, the articles are being presented by guests from Cedars-Sinai and from Indiana University. From Cedars-Sinai, the faculty discussant or introducer will be Dr. Donald Barrow, who was an associate professor of surgery, and then his second year fellow, Dr. Daniel Miles. We're also thrilled from Indiana University to have Dr. Greg Weston. Greg was a medical student a long time ago whenever I was just as a starting out faculty. He was a medical student here at UC Davis, so it's exciting to see his progression. And his 4th year integrated resident, Dr. Catherine Leckie. Joining us from the author side, we have faculty from the University of Washington, Dr. Nitin Singh, and his resident, Dr. Jake Hemingway, and then one of their co-authors, Dr. Michael Capps, who is the chief of surgery at Hawaii Permanente in Honolulu. We have our 2 guest moderators as well, which are Dr. Amy Reed. She is professor and chief of vascular surgery at the University of Minnesota. She's also the co-director of the Aortic Center, and she's secretary for the Society for Vascular Surgeons. So we're thrilled to have her here, as well as Dr. Leanne O'Banion, who is an assistant professor of surgery at the University of California, Fresno, and has a strong interest in peripheral artery disease. Just a couple of housekeeping things. We do ask that you stay muted. We encourage you to put questions in the chat for the discussants to kind of go over and to address with the authors. You may be called on to speak at some point. We do record this for on-demand access, so if you're not able to watch it or if you want to go back another time, you can. And then, of course, we have our December JVS Online Journal Club, which will be December 14th, which is 7 p.m. Central Time, hosted by Mal Sheehan at LSU. And of course, our original host institution from Thomas Jefferson University, who actually started this. So we're thrilled to kind of end the year with them hosting for us. We are sending out the sign out for 2022. So it'll go out to the program directors to sign up for next year. We have a few people who have already signed up. If you haven't gotten it, it should be coming in the next couple of days. So I will stop sharing my screen and I will turn it over to Dr. Barrow.
All right, just confirming everybody can see that. And here
looks good, yeah.
All right, great. Well, thanks to Dr. Humphreys and Dr. DiMuzio for the invitation. So tonight we'll be discussing an article from the University of Washington, as you mentioned, looking at their score for ruptured abdominal aortic aneurysm. So just a quick background. As you know, there's still approximately 4,000 ruptures per year in the United States. And despite a lot of advances, overall mortality for ruptured aneurysms remain upwards of 90%, with half of the patients failing to reach the hospital, and even those making to a hospital and undergoing intervention, that mortality still is in the range of 25 to 50%. And really, despite the endovascular therapy advances, we've still seen pretty high mortality for select patients. So obviously, there's great utility in the ability to predict outcomes. So an accurate risk stratification tool would enable us to optimize care, determining when or when not to transfer patients, when to intervene or decline intervention, really to help us appropriately counsel patients and or their families, and ideally provide cost-effective care. These tools really need to be simple, quick, and easily reproducible. So over time, there's been a handful of these. This is one, the more modern one from the VSGNE that utilized age, creatinine, and hypotension as factors. Another commonly utilized one is the Dutch aneurysm score, which uses age, lowest in-hospital blood pressure, presence of CPR, and a preoperative hemoglobin level. And then what we're going to be discussing tonight originally was described back in 2018 by the UW group, utilizing age, systolic blood pressure less than 70, a creatinine greater than 2, and a pH less than 7.2. And you can see here, we'll get into more of this tonight. So their most recent publication utilizing this has an updated patient cohort that really looks at the modern era, meaning really advanced endovascular therapy. They went and confirmed the accuracy based on their previous study. And I think really that our questions for the authors later on will be sort of what is the applicability and how do they utilize this in a real life setting. So we're going to transfer over to Daniel Miles, our second-year fellow. We're going to use the same computer to simplify life, hopefully.
And the same chair.
Does that make more?
All right, thank you everyone for the opportunity to talk tonight. And thank you to all the authors for this important paper. As Dr. Barrow said, I'm Daniel Miles. I'm the second-year fellow at Cedars-Sinai, presenting for the SVS Online Journal Club. So we're looking at this paper, the perioperative risk score accuracy confirmed in a modern ruptured abdominal aortic aneurysm experience. And our outline here will be objective, context, methods, results, and conclusions. So the objective of this paper was to prospectively validate the accuracy of the Harborview risk score, or HRS, in a modern cohort of patients treated for ruptured abdominal aortic aneurysms. As Dr. Barrow went over, we have our variables here: age greater than 76, creatinine greater than 2, systolic blood pressure ever below 70 millimeters of mercury, a pH less than 7.2 at any point. Each one of these is graded with 1 point for a total scale of 0 to 5. In context, as Dr. Barrow discussed, there are several existing mortality predictors for ruptured AAA, but they do have mixed reproducibility and usefulness. And the treatment of ruptured AAAs has evolved, but it does remain labor intensive, resource intensive, and with a high mortality. The Harborview risk score was developed from a retrospective review of ruptured AAAs treated at Harborview from January 2002 to October 2013. The methods for this paper: it is a single center retrospective review of a prospectively managed database of ruptured AAAs treated at a quaternary referral center. The total data collection was from January 2002 to December 2018. Total patients treated of 391. They did divide this into 3 separate eras. The earlier pre-EVAR era with 133 patients from 2002 to July 2007. The mid era, which is pre-Harborview risk score, but post EVAR utilization for ruptured AAAs from August 2007 to October of 2013 with 152 patients. And the modern era, which we're going to focus on from November 2013 to December 2018, 106 patients. And this is after the development of the Harborview risk score and utilization of EVAR. We're looking at the 30-day mortality of the modern cohort compared with the pre-EVAR and pre-Harborview risk score cohorts and assessing the validity of this HRS score and predicting the mortality within 30 days of these patients. Here's a table, a few tables with some nice results. You can see the odds ratio per unit increase in HRS. So for every point added in the score, every one of the variables identified that they had. Looking at all cohorts, the odds ratio was 2.7 per unit increase. And then looking at just the modern cohort, the odds ratio was 4.0 per unit increase in the Harborview risk score. Notably, the open aortic repairs had 45 patients, and the odds ratio there was 3.7, and with EVAR it was 4.2. You can see spelled out here on the bottom right by HRS score, the mortality percent in the modern and in the development cohorts. And then looking at the left, I feel this is a nice way to look at it with the bar graphs. You can see a nice relationship between the Harborview risk score and the probability of 30-day mortality. So looking at factors that are predictive of the 30-day mortality after ruptured AAA repair across all the cohorts, as we demonstrated in the last slide, the Harborview risk score was found to be statistically significant and good at predicting 30-day mortality. No one is surprised by the repair type, open versus endovascular repair, being relevant to the 30-day mortality. And then also they found that INR greater than 1.8 or less than 1.8 was predictive of 30-day mortality, as well as a heart rate greater than 110 versus less than 110. And this remains significant after adjustment for the Harbor V risk score and other variables. Looking at the 30-day mortality in open repair only from the development to modern cohort, we also see a decrease in overall mortality in the development cohort. That is the first two. We see an overall mortality of 55.9 versus in the modern of 40. Some of this is attributable to surgeon ability and as well as taking care of these patients and developing better ability to take care of these patients in the postoperative setting in the ICU. And then interestingly, looking at the utilization of comfort care across these cohorts, you can see by Harbor V risk score, the utilization of comfort care was not necessarily related to the risk score. This is again looking at all 26 patients across the cohort, so not just after implementation of the Harbor V risk score. In conclusion, the Harbor V risk score is accurate in predicting 30-day mortality after repair for ruptured AAA. This tool can assist in counseling patients and family members regarding the prognosis and treatment options. And some future directions may include assessing the generalizability, inclusion of those additional risk factors that we discussed, and the utility of utilizing the HRS in guiding treatment decisions by physicians. Thank you.
Great. Thank you, Dr. Miles. Excellent presentation and highlighting of a really important paper, and certainly something that I think we all struggle with. And let me just start off with one question from Dr. DiMuzio in the chat, and then I've got one as well. Dr. DiMuzio comments, I think this is great. However, is the HRS exactly that, just for Harborview? How applicable would it be in Philadelphia with 5 medical schools and a host of trauma centers? And I might add on top of that, you know, what we're hoping is applicability across, you know, the nation and beyond. So perhaps the authors could comment on that.
Yeah, sure. I'd be happy to. Thanks again for looking at our paper. We're really excited to be participating in this evening's journal club. So again, thank you for the invitation. I think one of the unique things about Harborview that is again kind of unique to our situation is the fact that we serve as the only level 1 trauma center and referral center for a 5-state region, which not only includes Washington, but also Wyoming, Alaska, Montana, and Idaho. And so we serve 27% of the US landmass. And I think that a lot of our patients are transferred from outside of the greater Seattle area. And what we found is that there's really no difference whether in mortality based on their transfer times or transfer distances. And so I think that the Harborview risk score acts as a way of really accounting for the differences in kind of the physiological state of the patient. And so certainly there's going to be questions about, you know, whether this is applicable to other patients. But I think when you look at the factors, you can see that they're more of a general state of how sick the patient is. pH, hypotension, age, they all kind of come together to give a physiological assessment of how the patient's doing in that moment. And I think the real strength of it is that they're very simple, they're very easy to use, and they're very simple to look at. And so if someone was interested in seeing how applicable this is to the greater Philadelphia region, one could pool all those patients and take a look pretty easily. So
just as a follow-up to that, do you have any analysis or subset analysis looking at the distance from your center? Because the earlier conception was, okay, if you can transfer, you're kind of selecting yourself out. But it sounds like you're saying that you've actually looked at that and understand that there's not a difference, it sounds like, whether you were transferred from the downstairs ER or you were transferred, 1,000 miles, or 100 miles away.
Yeah, we did find that implementing a streamlined transfer process and really getting patients into the OR fast did make a difference. But in terms of the actual distances, especially within the modern cohort, in looking at heat maps and looking at rates of mortality, it's really hard to say because we don't have the specific transfer turndown data. When we do not accept a transfer, when a patient dies in transfer, those don't make it into the database. And so We're missing the denominator is not exact, but what we can say is that of those patients that do make it here, certainly there doesn't seem to be a difference based on transfer.
Yeah, could I just ask, so are you or your co-authors actually using this now in transfer? I'm assuming certainly your modern presentation of those cohort is with this. So perhaps if yourself or Dr. Singh or Dr. Capps can comment on when you're on the transfer call, do you ask these 4 things, and do you then turn the patient down, or how is that going? And maybe Dr. Capps or Dr. Singh could answer.
Yeah, no, absolutely, Dr. Reed. So we use this all the time, and it's become a way of identifying things, because we get patients transferred from all over. One of the problems that happens is if you accept a patient that transfers and they end up dying here, then if they're from Montana, that's a cost to them. That's a cost to the family to drive out here. They're driving out here frantically trying to make it here. And so we use it all the time now. And somebody has all 4 factors. We tell them, start comfort care measures at your hospital, because the patient's not going to survive. And we
How is
spoke
that
to
met?
family members.
Do
What's that?
you find resistance with that?
Yeah,
Or
no, we do. There was actually, it was interesting. Just a couple of weeks ago, I had a patient, somehow it got transferred to the ER without us being involved. So when I got the call, I called, and this is they had all 4 criteria: that a distended abdomen, and they were trying to get a helicopter there. And, the last thing you want is, trying to code somebody at 5,000 feet. That's just not what you want to have happen. So we're able to say, look, let's not transfer this patient, and then we get a call 10 minutes later saying the patient expired. So we do get resistance. I do think that one of the majority of times, and I think people understand on this call, is that we don't, we're not talking to other vascular surgeons. We're usually talking in the emergency room, right? And they want to get the patient out of there because they think the patient could be saved, or they just don't want the patient to die there. And we have actually had discussions, and we say, let us talk to the family member and let them, let us explain what's going on. That being said, if somebody has a score of 3 and is transportable, do we say no all the time? No, we don't. But we do use it, and understand that, these patients that have a 3 or 4, yeah, you get them off the operating room table, but then within 30 days, we see that they may succumb to something else. So it's actually been very useful. And to answer Dr. DiMuzio's question, I think it's applicable everywhere, because it's factors. It's blood pressure, it's age, it's pH. It's not, it's not some unique factor with these patients. And as Jake said, it's looking at the hemodynamic stability of that patient at that time.
as a follow-up to that, Dr. Hingorani had a question about, and I think how many patients with 3 or 4 points were operated? And I think I saw in the modern area 0 with 4, a score of 4 were operated on. Is that right?
Yeah. So for in the total cohort, it was 39 people with HRS of 3 and 6 with an HRS of 4. Overall, it was roughly about 12% of the whole sample was stage 3 or 4. So it was relatively low compared to the other score categories.
Dr. Capps, was that in the modern era, or is that overall?
No, that's overall, but it held true in the modern. It really wasn't that different. So it's not a super common occurrence for somebody to have a score of 3 or 4. And that was true in the first 2 development cohorts and in the last cohort as well.
Okay, thank you. Dr. Lawrence had a question. During this study time, permissive hypotension was increasingly used for ruptured aneurysms. How might this approach affect several risk measures, including blood pressure and heart rate?
Yeah, I think that the definition for hypotension less than 70 at any point is far lower than our permissive hypotension. It certainly is. Yeah, we allow people to be hypotensive to some extent, but less than 70 is certainly an extension of that. We don't use the we don't use the heart rate currently for the heart review risk score, but it certainly would, and someone who's hypotensive would certainly be tachycardic. So if we do include that in the future, that's something to consider, definitely.
A question from Dr. Forbes. Great presentation, and thanks to Dr. Singh and Hemingway and colleagues for the work. My question is, at Harborview, is this mature enough that you use it to turn down patients whose treatment is futile as defined by the risk score? And I think we've been hearing that you have. So if if it's a 4, are you pretty much 100% on the transfer that you don't transfer?
Yeah, I wish I could say everything was 100%, but the majority of us do, and we have people, and it's tough. It's a tough situation, as you guys all know on this call, that when somebody's calling you and they're like, the patient can make it to your hospital, and that that's the case, and but I think sometimes people get talked into it, but the majority of times, yes, we are using it, and I think we're becoming better at enforcing, like 4s. We try to enact comfort care measures.
Well, this is just really super important information, because I think the more we're honing in on this in the literature and putting this forward as you have prospectively, it really helps all of us in saying the literature helps back this up, because this is one of the most difficult calls, I think, for everybody on this call to have with an outside facility. And so I think the more we can continue to hone this in like you've done is really great.
And I'll add on, I think just as important as a score of 4 is a score of 2, which is still associated with a 68% mortality. And a lot of patients, their family members don't necessarily realize just how sick their family member is. You get them through the surgery and they think they're through the woods. And I think it's a really great opportunity as part of the team to really set up the expectation that this is going to be a long treatment road. And even though we got through the first step, this is really a marathon phase. And we have a long ways to go. We have to expect setbacks and very closely watch after these patients. And so I think just as important is when you see them in the preoperative area, being able to say, someone as sick as your father or mother, is very sick. And if they want to know the numbers, you certainly can share that with them. And it just sets the expectation that just because they get through that first surgery doesn't mean that we're through the woods quite yet. And it helps just prepare them for the long road that's going to come, which I think is really
Dr. Richards has a question. The presentation summarizes the manuscript. Question, this represents internal validity of a database over 20 years. How were those patients not referred to vascular included in the analysis? In other words, how was selection bias avoided?
Yeah, so this was just patients who were treated at our institution, which does include comfort care, treated at our institution with ruptured aneurysms. And so patients treated outside in the community, which is increasingly happening, or patients who don't make it to the hospital aren't included. So there's no way to account for that, unfortunately. We don't have that information.
Okay. Question from Dr. DeHolos. I apologize if I'm mispronouncing that. I think it would be useful to look at pre and post-COVID era mortality rates for ruptures, as anecdotally increased transfer times to tertiary centers, oversaturated local hospitals seem to contribute to increased mortality. So absolutely. I wanted to just ask, it seemed the INR was that a higher INR and a lower INR, but the cut point seemed to be 1.8. Can you maybe just clarify what the issue was with that?
Well, the INR was actually a pretty strong predictor. And that was after taking into account the Harborview risk score and whether they were fixed with an open or an endovascular repair. The heart rate was a weak predictor. I wouldn't put much stock in that, but the INR was kind of remarkably strong and probably something that we ought to look at in future iterations of this project.
Question from Dr. Nazi. I stand corrected, but I get the impression that the HRS is not meant to be used in isolation in the modern era. From table 3, I see other independent risk factors. Won't it be more appropriate to incorporate all these risk factors into one risk score?
Yeah, and that's a great question. That's something we are looking at. That's what Dr. Capps was referring to, where we're looking at whether we can strengthen the score's accuracy by adding these factors, particularly the INR, given how strong the association is.
Only about 12% of the patients were on warfarin, but upwards of 40 to 50% had some abnormality in their INR, not greater than 1.8, but these patients obviously come in shock and they're coagulopathic, and it's not necessarily because they're on warfarin.
Right. Got time for just a couple more here. Dr. Burrell mentions, does this series include any complex such as fenestrated repairs, et cetera? And if so, which patients undergo open repair ruptures versus complex endo repairs? So any complex endo approaches here?
There definitely are. I don't have the numbers on hand currently, but we certainly have patients who have undergone physician modified endografts versus open repair. I think one thing that was really striking about the data that didn't really make it into the manuscript was that the mortality of open repair really dropped significantly in the most recent cohort. And as was mentioned in the final slide by the folks at Cedars-Sinai, it dropped from 60% to less than 40%. And, we don't fully understand why that happened. And so I think that there certainly are patients undergoing complex aneurysm repairs. We also endovascular repairs. We also know patients who are being treated increasingly off IFU with some complex neck anatomy and making that work. But with that being said, I don't have the exact numbers off the top of my head.
Yeah, I think the one thing on that would be, that it's rare that we do we'll do a physician modified endograft. Have we done it on symptomatics? Yeah, but usually these are middle of the night cases. Then, we have IDs here, but these are compassionate use kind of things. And in general, if somebody now presents with a juxtarenal abdominal aortic aneurysm that doesn't have a good neck, we're doing an open aneurysm repair. We found in our series previously that if you attempt to do an EVAR on these patients with an inadequate anatomy, particularly the proximal neck, we had 100% mortality. So, we stopped doing that. And I think that probably is one of the reasons, as Jake was alluding to, that our mortality's improved with the open. We just go direct to open. And I think we've got people that are experienced in doing open aneurysm repair.
That's fantastic. Now, I moderated a session at VAM in August with talking, and there was some talk about ruptures, and we brought up the idea, and Luis Sanchez at WashU mentioned that they sometimes will cover the renals and just, not in somebody that's, not doing well, not time for a physician modified. But from what you're saying, it sounds like they're not going to do well, even if you put them on dialysis right off the bat.
Yeah, that's correct. They don't do well. And, and I think that it's based on their presenting a physiology, which I think is why, we really believe in the risk score.
Okay, and I think I've got time for one last question, and I'd like to ask Dr. O'Banions, do you ever offer to discuss, and I think you may have answered this, with the families over the phone when they are at a very rural hospital where the ER providers give pushback or feel uncomfortable discussing, that they're not going to be offered repair? So maybe you can talk about, do you often have to discuss this? And specifically, when you are denying transfer for the fours, do you find that then you've got to discuss it with the families?
Yeah, I personally haven't, and I'll let Dr. Singh answer as well. But I do know in speaking with my attendings that many of them have spoken with family members directly and said, here's the situation, here's our recommendation, and here's what our experience has been. And families are very amenable to and thankful for that.
Yeah, I agree. It's a very powerful tool, Dr. Reed, to have to say and tell them your numbers and say, with the presenting factors that your father or husband has, he's not going to survive. In our series, we've seen this. And so when we say that, I think it's, it's pretty powerful. And I'll tell you, we don't have a ton that get to be 4 that we've turned down. They're usually in the tweeners, right? Between the 2s or so. But when they have all 4 and it's not looking like a good situation and they're, trying to come from far away, then, we tell them. And most of the time when you explain that to the family members, they understand.
Great. Well, this is like feeding meat to sharks. I feel like we could go on and on and on. It's awesome. If there are still many questions in the chat, and if perhaps some of the authors could perhaps respond to some of those, that'd be great. But thank you very much, and I'll turn it back over to Misty on the next topic.
Yeah, it's always hard when we have so much good conversation, but we do want to get to the next paper, although the authors for the next paper aren't here, so we may be a little bit lighter on the discussion. Next, we're going to have Dr. Greg Weston talk about the effects of supervised exercise paper, which I think will generate some pretty good discussion from it. So.
Sorry about that. If everyone can see that screen okay.
Looks good.
So I'm going to just talk very briefly about supervised exercise therapy before Dr. Lucky takes us away with the paper. So of course, we're all very familiar with peripheral arterial occlusive disease in the legs. And I think we like most patients, but I think especially as surgeons, we have the tendency to focus on, the anatomic site of disease. This is a disease of the arteries in the lower extremity. And this image is actually an image from the SVS handout for patients entitled Symptoms. So even in the symptoms section of our descriptions of this disease, we're including anatomy, looking down here at the artery in the leg, and here's a plaque, and that's the pathology that we are treating. And we are very successful at treating that, right? Whether with open or endovascular techniques, we can treat those arteries and improve those symptoms, whether it's claudication or limb-threatening ischemia. But one of the things that many of us love about vascular surgery is that we're not merely technicians, responding to our oculostenotic reflex by bypassing or stenting or some other intervention, but we're managing vascular patients in all their complexity. And a large part of this is managing their systemic diseases. So when you think about systemic atherosclerosis, then you get into all the other therapies that we offer to patients. And many of our therapies are not targeted only at the legs. So our medical therapies are designed not only to reduce risk to the limb, but also to reduce systemic complications. And that's why, of course, we're all urge all of our patients to be on antiplatelet therapy and statins and smoking cessation, antihypertensives, et cetera. So when we then expand this to think about another therapy for the lower extremities of supervised exercise. The first question that I usually get when talking to patients about this, that I'm sure you do also, is, but doc, I can't walk. That's the whole point. I'm here because I can't walk. Why would you tell me that I need to go do walking therapy? And it seems counterintuitive, especially to claudicant patients. And this is why I thought it was particularly novel and interesting when I learned about the work of the late Alan Hirsch from the University of Minnesota. And we're lucky to have Dr. Reed with us from University of Minnesota tonight. And he and other investigators did the wonderful, clever trial, randomizing patients to supervised exercise versus medical care versus stent treatment. And I think pretty remarkably showed that the set patients, the supervised exercise patients, improved as much or more than patients getting an intervention. So I always mention this when I'm talking to patients about trying to encourage them to participate in supervised exercise. And then the question is always, well, why does this work? And how does it work? I usually explain it in terms of thinking about collateral development, but there are actually lots of mechanisms that have been studied in the biology of thinking about exercise therapy, changes in endothelial function, changes in angiogenesis, capillary density, oxidative metabolism, oxygen extraction, blood viscosity, muscle intervention, walking economy. There are lots of reasons why someone who walks might then become better at walking and might have reduced pain and have the ability to walk further. So we have this recommendation from the SVS that we recommend in patients with claudication, a supervised exercise program to improve functional status, to improve quality of life, and to reduce leg symptoms. But I think the question, a big question for me then is how do we go from this treatment of the lower extremities to thinking about the rest of what supervised exercise does for the body. And so supervised exercise therapy is expanding. 2017, CMS approved supervised exercise for Medicare, and now it's being increasingly covered for private insurances. And now SVS is rolling out an app to encourage home-based exercise therapy, where you have an app and patients can use that to encourage them to walk, set goals, get encouragement and reinforcement from sending messages to a healthcare provider, and then get feedback about how they're improving. And through this coaching, hopefully see improvements like we see with supervised exercise, on a treadmill or in a healthcare setting. And this is really very timely, especially in the time of a pandemic. It's the perfect time to be trying to roll out a app-based intervention. I think that's wonderful. The questions that I have are sort of what is next for supervised exercise? Patients who've been revascularized and are no longer claudicating, what should we do about them? There is some data that exercise therapy continues to provide benefit after revascularization, but many of these patients who are not having that pain may not be motivated to continue doing so. And so we have to make sure we demonstrate those benefits. And in addition to the benefits for the limb, a related question is, what are the benefits for systemic disease? And that's a large focus of what this paper is about. And then the remaining question, which isn't fully answered by this paper, but which maybe hints at some of them, is what are the mechanisms by which supervised exercise causes any improvements that we're seeing, because of that long list of things I mentioned about ways that it might potentially cause benefit. All right, I'm going to cut myself off and let Dr. Leckie go now.
All right, can everyone see the single slide screen?
I don't see anything yet.
And how about now? Excellent.
Thank you.
All right, my name is Catherine Leckie. I'm the fourth year integrated vascular resident at Indiana University. And as Dr. Weston already said, I will be presenting this journal article, Effects of Supervised Exercise Therapy on Blood Pressure and Heart Rate During Exercise and Associations with Improved Walking Performance in Peripheral Arterial Disease, Results of a Randomized Clinical Trial. So I'm just going to go ahead and jump right in. If I can make my slide advance. So this study was a post hoc analysis of data from the PROPEL trial. This was a randomized clinical trial, double-blinded, investigating whether granulocyte macrophage colony stimulating factor plus or minus supervised exercise therapy improved 6-minute walking distance at 6 months. This was original trial was a 2x2 factorial design with 4 groups. The results of this study were published in 2017, and they did not demonstrate any clinical efficacy in the GM-CSF therapy, but did show an increase in 6-minute walking distance in the supervised exercise therapy compared to the control and the placebo groups. I think this finding reinforced what we already know, but having all this data available to them in the clinical trial probably was what prompted them to hypothesize that the supervised exercise therapy would decrease blood pressure and heart rate during exercise, and that a greater decrease would correlate with greater improvement in performance during exercise testing and better self-reported walking performance. Because the GM-CSF therapy did not significantly improve walking distance for this analysis, and in order to increase statistical power by increasing sample size, the GM-CSF and the placebo groups were actually pooled to create 2 treatment groups, supervised exercise therapy and control. Perforce, the inclusion-exclusion criteria, intervention, and outcome measurements were those of the original trial. Patients were recruited through advertising, physician referrals, and by contacting prior research participants. The included patients had some objective documentation of peripheral arterial disease, including decreased ABI, a provoked decrease in ABI, or other non-invasive or angiographic evidence of peripheral arterial disease. The patients were either asymptomatic or had claudication only, as critical limb-threatening ischemia or active wounds were exclusion criteria. Patients were excluded if they were already exercising at a similar level, or if they had a significant mobility impairment or a comorbid position that might be expected to affect exercise tolerance or performance, such as Parkinson's or symptomatic heart disease, or conditions that were associated with decreased life expectancy, such as cancer with a poor prognosis. The supervised exercise therapy intervention consisted of treadmill exercise supervised by an exercise physiologist. Participants started at 15 minutes, and this was gradually increased over their sessions until 50 minutes of exercise per session was achieved, and they met 3 times a week for 24 weeks. The control group consisted of weekly 1-hour education sessions on health topics that were led by Northwestern University faculty. So a number of outcomes were evaluated. The graded treadmill exercise test was protocolized with participants walking at 2 miles per hour and having a grade increase by 2% every 2 minutes. And they were asked to walk for as long as possible. Measurements included the distance they walked and the vital signs at the end of each 2-minute stage. The 6-minute walk test was completed as usual, with patients being asked to walk as far as possible in 6 minutes over a flat level surface, such as up and down a 100-foot hallway. Other outcomes looked at included flow-mediated dilation of the brachial artery. This was defined as the ratio of the maximum brachial artery diameter after reactive hyperemia to the resting diameter, with reactive hyperemia being induced by blood pressure cuff inflation greater than systolic blood pressure for 4 minutes. The walking impairment questionnaire was a questionnaire asking the respondent to assign a walking difficulty score to a variety of specific distances, such as walking indoors, walking 1,500 feet or 5 blocks, etc. And these were added for a total score, with a higher score being better. ABIs were calculated in the usual fashion. This data was all collected as part of the PROPEL study protocol, and this was used for the analysis in the article under discussion. So as far as their analysis went, the statistics included a baseline comparisons with the expected T and chi-squared tests. Paired t-tests were used to compare changes from baseline within each group. And these results are listed in their somewhat extensive tables that were included in the manuscript, but I don't think I'll go into the within group comparisons. The actual meat of the analysis consisted of a mixed effects regression model to compare changes in blood pressure, heart rate, and pulse pressure between 0 and 6 months between the groups. This type of longitudinal data analysis was used to account for within-person correlations among outcomes and included a patient-specific intercept to account for baseline differences between the patients, as well as a time effect, that's at 0 and 6 months, a stage effect, meaning for each of the first 5 of the 2-minute stages of the graded treadmill exercise test, as well as, of course, the group effect. The final portion of the analysis looked at correlations between the change in blood pressure, heart rate, pulse pressure, and the change in the 6-minute walking distance, treadmill walking distance, WIQ scores, and FMD. So for our results, of the 210 participants in the original trial, 84% completed 0 and 6 month testing and were included in this analysis. As shown in the main trial, the supervised exercise therapy did significantly improve both 6-minute walking distance and the treadmill walking distance, the former by 27 meters and the latter by 210 meters. I did not see any analysis included in the manuscript of whether or not the supervised exercise therapy increased the flow-mediated dilation, the WIQ scores, or the ABI, which I thought was interesting. With regard to the effect of 6 months of supervised exercise therapy on vitals during the graded treadmill exercise test, overall systolic blood pressure was decreased by 12 millimeters of mercury, and by individual stages, a statistically significant reduction was found in stages 1 through 4. Diastolic blood pressure during the graded treadmill exercise test was not significantly different, and by stages only decreased significantly in stage 1. 6 months of supervised exercise therapy also resulted in statistically significant decrease in overall pulse pressure, which you would expect given the systolic was decreased and the diastolic wasn't. During graded treadmill exercise testing by 9 millimeters of mercury and by individual stages, a statistically significant reduction was found in stages 1 through 4. There was an overall decrease in the mean heart rate by 7 beats per minute, and this difference was also significant in all 5 stages. The final portion of the analysis looked at correlations between the change in blood pressure, heart rate, and pulse pressure during the treadmill exercise and the change in the 6-minute walk distance, treadmill walking distance, WIQ score, and FMD. With respect to the 6-minute walking distance, decreases in systolic blood pressure, pulse pressure, and heart rate all had a statistically significant correlation with increase in walking distance, while diastolic blood pressure did not. For the treadmill walking distance, similarly decreases in systolic blood pressure and pulse pressure correlated with increase in walking distance, but diastolic blood pressure and heart rate as well did not. With respect to flow-mediated dilation, no significant correlations were found. And interestingly, only a decrease in overall heart rate correlated with higher WIQ scores, while changes in systolic, diastolic blood pressure, and pulse pressure were not significantly associated. So in conclusion, 6 months of supervised exercise therapy does result in statistically significant hemodynamic differences during graded treadmill exercise test. And the greater the improvement in hemodynamic response, the greater the benefit in walking distance. This study was underpowered to detect differences in mortality, morbidity between groups, but previous studies have shown that an exaggerated increase in systolic blood pressure during a treadmill test is associated with an increased risk of major adverse cerebrovascular and cardiac events over the next 5 years. The authors suggest that the improved functional performance after supervised exercise therapy may result in a decrease in blood pressure and heart rate by ameliorating the activation of the exercise pressor reflex. This is consistent, I think, with the fact that the later stages tended to have lower absolute differences and the fewer significant comparisons compared to the earlier stages in the exercise testing. The main limitations of this analysis mentioned by the authors include its post-hoc nature, the lack of adjustment for multiple comparisons, no unsupervised exercise group, and of course, the fact that half of these patients did receive their GM-CSF treatment, although they did include a sensitivity analysis excluding those patients that did not demonstrate any significant difference in the results of the analysis. And with that, I'll open it up to questions and discussions.
All right, thanks. That was a great presentation. There's a lot of data in this manuscript. I think we have a question from Dr. Hingorani. Do these data not suggest that SET may affect long-term cardiac mortality in these patients with symptomatic PAD? And I think that was one of their biggest limitations, in that they didn't have long enough follow-up outcomes to detect that. And I think that's probably one of the biggest questions, is kind of is this going to impact, because at the end of the day, if we're getting supervised exercise therapy on every single patient with any diagnosis of PAD, that could be a substantial cost to our healthcare. And so is it worth it? I think it's an interesting thought. I don't know if you guys have any other thoughts on that.
Yeah, I think Dr. Lucky mentioned that, that they didn't find a significant finding related to mortality. And they mentioned in their discussion that that there have been some previous observational studies that have suggested a relationship, but of course there's lots of confounders associated with those studies. And they also mentioned that most trials of this are going to be underpowered to detect a difference, because even though we know that claudicants have significant cardiovascular morbidity, they're usually not in the 6-month time frame and usually not at terribly high rates. So you'd have to run a pretty big trial or for a pretty long time to do that. My thought about that was that the population in whom you might study that would be a revascularized population, because you have a population that you don't already have a proven benefit. In a claudicant population, is it really ethical to randomize people to exercise if you know that they're going to get a benefit in their claudication from exercise? But in the revascularized population, maybe it'll prevent them from dying, but maybe it's just going to be an expensive intervention over 5 years. So I
also thought it was kind of interesting that a very small cohort of this patient population actually had intermittent claudication. So, 60 to 75% of the entire cohort had no issues with walking. And so, it would be interesting to know a sub-analysis of those that had actual intermittent claudication and if they fared differently compared to those that just had asymptomatic PAD. We have another question by Dr. Richards. In this study, the endpoint assessed in this analysis was blood pressure. However, did they control for the confounder of medication? And those patients seemed 3 times a week, they may have received better blood pressure monitoring and therefore better medication. Could improved blood pressure endpoint reflect the Hawthorne effect? Greater attention to detail leads to better results.
So they did do a breakdown of a couple of blood pressure medications in table 1 that seemed pretty similar, looking just at beta blockers, ACEs and ARBs, and calcium channel blockers. They didn't include the p-values, but the numbers look pretty close. Of course, it doesn't go into whether or not additional medications were started.
Lucky, your audio is cutting out a bit.
Yeah.
But I think she's pointing out that they did look at the the issue of were there medications that were different between the groups. But I think Dr. Richards is also alluding to the fact that even if you were on similar medications, you might have had better titration of your blood pressure control if you were seen more often. And I don't think that they did control for that. They of course had some of these patients who were getting cell treatment, and those patients might have been seen more often and might have been getting more monitoring. But not only are they seen 3 times a week for the supervised exercise, but they're getting seen 3 times a week and getting blood pressure and heart rate monitoring during those sessions, as opposed to their control intervention of the health counseling, where I'm guessing that they were not on blood pressure and heart rate monitors during their counseling sessions. So that certainly is a potential confounder.
And then another question that Dr. Richards had was, how would you design a study to assess the intervention of an all-cause cardiovascular risk and long-term patient outcomes? That would be quite challenging.
Yeah, so, I mean, I suggested the thought of looking at patients who were, not claudicating, who could be followed over time with supervised exercise versus not. But I would love to hear ideas from the group about, number one, how you would enroll people who would be willing to participate, and number two, how what is your control going to be? There's the question of supervised versus unsupervised exercise. Are you really going to tell a population that they should not be, you're not encouraging them to exercise? Of course, we're going to all encourage our patients to engage in cardiovascular activity. But what is the appropriate control for a long-term intervention? I would think it would be something like, usual care, our usual encouragement to general exercise, as opposed to a supervised structured exercise program.
Well, and the other question is, basically this just shows that anybody who exercises does better, and their heart rate decreases, their blood pressure decreases, which we kind of all thought about and we know. And so I think insurance companies are starting to pay for gym memberships. They're starting to pay for, different various kinds of exercises. So is it a bad thing to just, across the board, encourage exercise in everybody, not just patients with asymptomatic PAD or claudication or peripheral vascular disease? Should we just educate everybody, exercise everybody? And that equals better health across all of our patient population across the globe. And how do we balance that in picking out which populations should benefit from supervised exercise therapy versus, the entire country?
Yeah, I appreciate Dr. Richards' other comment here, saying that, this is not necessarily bad data, but we have to think about what we can do with these data. And thinking about what we can do with data like these, one possible use of these data is essentially marketing to our patients, right? Of course, we have an interest in finding the truth about mechanisms of altering their cardiovascular morbidity and mortality, and thinking about how the exercise is related to hemodynamics and things like that. But I think one potential outcome of data like these are that we can point to them as reasons to encourage people to engage in exercise. And not that there's a shortage of evidence for exercise, but perhaps this is one of the things that you can use that's specifically related to your claudicants that or your PAD patients to encourage them to exercise.
All right. I think we're getting close to the hour. If there's no more questions, I'll turn it back over to Dr. Humphries.
Well, there's a lot of great discussion. If you want to stop sharing your screen too, that will allow us to kind of get a good feel for everybody that's still here. Lots of great discussion tonight. It's just so exciting to read some of this and get the conversation going. We will have our next journal club in December. We thank everybody. We send out an email beforehand. It's advertised on social media. And again, the program directors will be getting an email to sign up for 2022 if you haven't already. Thank you all for a wonderful night.
Thank you for all the contributions to the discussions too. Thank you. Hi, Peter. Thanks a lot.
Thank you for having us and everyone for contributing.
Yeah. Have a nice Thanksgiving.
Thank you.
Night, everybody.
Good night.